Welcome to today's Michigan WIC Formula Update. Our first presentation will provide information about infant and pediatric products and their indications. My name is Jan Cox, and my intention is to provide you with current information about these products and their indications, and to bring you at least a little of my perspective from nearly 40 years of experience as a dietitian working in the area of neonatal and pediatric nutrition. The objectives for this presentation are to identify compositional differences of contract formulas for infants and toddlers, to identify indications for use of specialty formulas for infants and toddlers, and to discuss methods to handle common infant feeding problems with respect to formula products and their indications. To meet these objectives, I would like to present an overview of the contract infant and pediatric formulas and their ingredients, cover the indications for special infant and pediatric formulas, and finish with a few real-life examples using this information. Our mission at Michigan WIC is, of course, to support breastfeeding as the preferred method of infant feeding. As you know, the benefits are numerous and go well beyond the brief list presented here. But there are often barriers to successful breastfeeding, not the least of which is our society's expectation that mothers quickly return to the workplace, a workplace that may or may not be very supportive of breastfeeding, even though workplace policies intend to be supportive, at least on paper. In the United States, over 80% of infants receive at least some breast milk, but only 44% are exclusively breastfed at 3 months of age, and only 52% are still receiving at least some breast milk at 6 months of age. Breastfeeding numbers overall in Michigan are similar to national numbers, but are a bit lower in our Michigan WIC population. Barriers are numerous for our population, and every family needs to do what works best for them, given the ultimate priority that each infant is fed adequately to support optimal growth and development. But what this really means, practically speaking, is that many of the infants receiving our support receive infant formula. So we really need to know what the formulas are inside and out, meaning what's in the can and what's on the label. The retail scene is rife with options, and now that the manufacturers of infant formula are marketing to the end user, consumers often know more about what is available than I do. Before we jump into the formulas and their indications, I'd like to take at least a brief look at some of the ingredients that set one formula apart from another, both for the standard formulas and for the specialty formulas. The differences between the various standard formulas primarily include differences in the types of protein and carbohydrate. The specialty formulas also differ in protein and carbohydrate, but also in fat and sometimes the amount of minerals. Although human milk fortifier is not a formula, we will look at it briefly and review its use. Pediatric formulas differ in their caloric density and whether or not they include fiber, but also in their protein, carbohydrate, and fat content. Some differences in nutrient content, for example, the higher protein and mineral content of preterm infant formulas, or the lower energy content of reduced energy blenderized tube feedings, are usually pretty easy to identify. But there are other differences in individual ingredients that allow for other indications, which may or may not be as clear-cut. So let us take a few minutes to look at the ingredients that set one formula apart from another, most often different proteins, fats, carbohydrates, prebiotics, or fiber, before we address individual products and their indications. Although probiotics are also one of these game-changing ingredients, I will not cover probiotics beyond their definition, partly because this topic extends beyond my level of expertise, and, well, because this really opens up a can of worms, or at least a petri dish or two, that would extend this presentation beyond its allotted time. So please forgive me if you were hoping for some truly meaningful information about probiotics. In general, the protein source for most infant formulas is cow's milk, casein, whey, or both, although soy milk, goat's milk, and individual amino acids are also used in infant formulas. Pediatric products are similar, except that the blenderized product also includes chicken and peas as protein sources. The most common reason to look at the type of protein content is allergy, given that it is protein and not carbohydrate or fat that can cause an allergic response. There are two ways of looking at products to determine whether or not a product is hypoallergenic. Historically, the size of the protein has been used for definition, less than 3 kilodaltons. When protein is hydrolyzed or even extensively hydrolyzed, there may be residual protein chains that are not less than 5 or 3 kilodaltons, respectively. A more practical and the current generally accepted definition of a hypoallergenic formula is one in which less than 1% of the nitrogen-containing substances are immunoreactive, or at least 90% of the subjects with known protein sensitivity have proven tolerance. Most infant formulas contain DHA and ARA fatty acids derived from algae and fungus respectively. Recommendations in the literature extend to age 2 for DHA, so some of the pediatric products have DHA added, but some don't. But the more defining difference in fat content relative to indications is the medium-chain triglyceride content. For absorption to occur, MCTs do not need to form micelles, so they don't need bile acids. Gastric lipase may be sufficient for hydrolysis, and some absorption may occur without hydrolysis. A common misconception or oversight in using MCT oil regards essential fatty acids. The only two essential fatty acids for humans are linoleic and linolenic acids, both of which have 18 carbon chains, not 8 to 12. To provide adequate essential fatty acids, another oil must be given in addition to MCT oil, one that contains linoleic and linoleic acids. Of note, DHA has 22 carbons and ARA has 20. A variety of carbohydrate sources are used in both infant and pediatric formulas. Lactose is the primary carbohydrate in human milk, so it makes sense to use it in substitute infant formula products. Lactose does require the enzyme lactase for absorption. Lactase is produced at the tips of the villi, not in the crypts. Profuse diarrhea can sometimes increase sloughing of cells in the GI tract, and the tips of the villi are the most vulnerable. Cellular turnover is very rapid in the GI tract, so even if a temporary lactose intolerance occurs, it usually resolves quickly enough that no intervention with a lactose-free formula is needed. Sucrose is used to enhance flavor as much as provide carbohydrate. Blenderized products, used most often as tube feedings, include fruit and juice, not so much to enhance flavor as to provide some of the carbohydrate as the foods that would normally be consumed orally. Corn-derived carbohydrates are both simple and complex, and everything in between. But the real mixed bag is carbohydrate sourced from corn, which can be as simple as dextrose and as complex as cornstarch. Although you may never use this information in your day-to-day practice, I thought a bit of information might be fun given that we dietitians, at our core, are math science geeks, with a yen for practical application. Maltodextrins from corn are hydrolyzed to form less complex saccharides, ultimately maltose and dextrose, but many others in between. The dextrose equivalency, in the case of corn syrup the percentage of maltose and dextrose, is a measure of the degree in which a complex carbohydrate has been hydrolyzed. The greater degree to which corn syrup or maltodextrin is hydrolyzed, the higher the amount of reducing sugars. For example, the carbohydrate content of corn syrup solids with a DE of 33.7 is about 7% dextrose, 26% maltose, and 67% higher saccharides. The carbohydrate content of maltodextrins with a DE of 4.8 is about 1% dextrose, 3% maltose, and 96% higher saccharides. Product labels, of course, do not tell us the degree to which a saccharide has been hydrolyzed. However, since carbohydrate usually makes the greatest contribution to osmolality, osmolality increases as the amount of maltose and dextrose increases. So a product with a lower osmolality likely has a more complex carbohydrate with a lower DE score. A product with a higher osmolality likely has a simpler carbohydrate with a higher DE score. Although higher osmolality can sometimes affect gastric emptying, the rate at which simpler carbohydrates are absorbed also increases, as less digestion is needed prior to absorption. Fun digression, right? Well, maybe not for everyone. On to prebiotics. A prebiotic is defined as a selectively fermented ingredient that allows specific changes, both in the composition and/or activity in the gastrointestinal microflora that confers benefits upon host well-being and health. The oligosaccharides and polydextrose components in infant formulas are meant to provide prebiotics in amounts similar to that in breast milk, though providing the variety of oligosaccharides wouldn't be practical, given the 200 distinctly different structures of prebiotics that have been identified in breast milk. Galacto-oligosaccharides are synthesized from lactose and consist of short, variable length chains of galactose ending in glucose, while polydextrose consists of random, highly branched glucose polymers plus sorbitol. The benefit conferred is softer, looser stool patterns similar to that reported for breastfed infants, increased populations of beneficial bacteria, Bifidobacterium and Lactobacillus species, a composition closer to that of breastfed infants, increased fecal secretory IgA, and support for normal immune function by interfering with the adhesion of pathogens to epithelial cells. The fiber in pediatric products is meant to provide the fiber that would be consumed from whole grains and fresh fruits and vegetables in a normal diet. Soluble fiber helps promote the growth of beneficial bacteria, and insoluble fiber helps support normal bowel function. Some fiber sources contain both soluble and insoluble fiber. My definition of probiotics is simply live bugs, but the World Health Organization has adopted a more specific definition. Live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. There are health claims from reducing incidence and severity of necrotizing enterocolitis in preterm infants to preventing allergy symptoms. Strains, dose recommendations, and dose response reports vary tremendously. After all, a lot depends on the bugs that are already there or aren't there in the GI tract. Study reports evaluating the number of active coliform counts compared to label claims also vary. Information varies so widely that I have found this a very difficult topic to tackle. Of course, I like to blame this on having started my college career as a chemistry major, not a biology major, and some not so pleasant events in the microbiology lab class I had to endure. The only product I think with a probiotic on the Michigan WIC list is Nutramigen with Enflora LGG, or Lactobacillus rhamnosus GG, which product information states is the most effective strain for infants with cow's milk protein allergy to support healthy and normal functioning of the GI tract. Let us now turn to the actual products we have available. The characteristics of Enfamil Infant include intact cow's milk protein with an adjusted whey casein ratio from the 1882 typical of cow's milk to the 60/40 typical of human milk, although the whey protein of cow's milk is different than the whey protein in human milk. Lactose is the sole disaccharide. Prebiotics include both galacto-oligosaccharide and polydextrose. Gentilese is indicated for symptoms of fussiness and gas. Gentilese provides protein content as partially hydrolyzed milk proteins, by definition less than 5 kilodaltons in size, so it cannot be labeled as hypoallergenic. Gentilese cannot be used for infants with known cow's milk allergy and cannot claim allergy prevention. Corn syrup solids comprise the bulk of the carbohydrate content, so if an infant is especially fussy and gassy after a bout of diarrhea, it might make sense to use this product, although there are no prebiotics present to help normalize bowel microflora. The newest player on the scene is Reguline, which is indicated for softer stools, but it also has partially hydrolyzed casein and whey protein, as is in Gentilese, an altered carbohydrate content, decreasing the lactose content to 50%, which is not quite to the extent in Gentilese, and prebiotics, galacto-oligosaccharides, and polydextrose, as in standard Enfamil Infant. Enfamil AR is indicated for uncomplicated gastroesophageal reflux, along with appropriate lifestyle changes. First and foremost, avoiding overfeeding by close attention to feeding cues, but also providing smaller volume, more frequent feedings, attention to lip seal on the nipple to avoid air swallowing, and frequent burping. Upright positioning after feedings has mixed reviews, but may also be of help in preventing reflux. Lactose still comprises the bulk of the carbohydrate content, but rice starch is present to increase the viscosity of the formula, particularly as it hits stomach acidity. Stomach acidity is reduced, of course, if antacids, histamine 2 receptor antagonists, or proton pump inhibitors are part of the therapy, which should only be used for GERD or gastroesophageal reflux disease or complicated GER. Although some physicians are still recommending the addition of rice cereal to feedings to treat GER, I have found this happens much less frequently. Adding rice cereal to formulas, of course, upsets the distribution of protein, carbohydrate, and fat, and provides a very calorically dense feeding, not to mention additional iron. Soy formulas are used far less today than in the past, primarily due to a shorter list of indications and cautionary use in some situations. Here it makes sense to review some allergy information because the greatest difference in indications for soy formulas has been related to allergy information. Since allergy testing is not generally reliable in infants, we are probably limited to the words suspected allergy or intolerance, but an IgE-mediated allergy or intolerance is characterized by occurring rather immediately within 1 to 2 hours, having cutaneous symptoms, urticaria, angioedema, or hives, gastrointestinal symptoms, oral itching, abdominal pain, vomiting and diarrhea, and respiratory symptoms, wheeze, laryngeal edema, rhinoconjunctivitis. This may ultimately result in anaphylaxis, with an 8 to 15% of food-related fatal or near-fatal reactions due to cow's milk protein allergy and less than 1% due to soy allergy. In this type of allergic response to cow's milk, 10 to 14% of cases may also react to soy protein, and 10% may also react to extensively hydrolyzed protein formulas, primarily due to residual proteins that are greater than 3 kilodaltons in size. Mixed IgE, non-IgE symptoms are primarily atopic dermatitis, 40% of which may be food-related, and both milk and soy are in this list. Non-IgE reactions to food proteins are now referred to as FPIES, or food protein-induced enterocolitis syndrome. These reactions are characterized by profuse vomiting and diarrhea within 2 to 3 hours, dehydration and lethargy, occult blood loss, fecal smears that include leukocytes and eosinophils, failure to thrive, and hypoalbuminemia. What is especially important relative to soy formulas is that 45%, range being 30 to 64%, of infants that react to milk-based formulas will also react to soy. In fact, 30% of those who react to milk will also react to extensively hydrolyzed protein. For these reasons, the American Academy of Pediatrics published a position paper on soy formulas in 2008, when soy formulas comprised about 25% of the market share. 1 year later, market share for soy formulas fell to 13%. Use of soy formulas in the Michigan WIC program also fell from 19% to less than 7%. Moving on to the pediatric products, the standard formulas are quite similar in composition, differing somewhat in fiber source, although both contain soluble and insoluble fiber. The indications listed in the product information are a little different, though both certainly include malnutrition, and at risk for malnutrition would, by definition, include inadequate oral intake and increased energy needs. Both can be used as a sole source of nutrition. The tube feeding products are different primarily in ingredient source, though the nutrients provided are adequate from both. And indications are similar, although complete pediatric includes a reduced calorie product, which provides the recommended nutrients with less calorie intake for clients with reduced energy output, either due to reduced expected growth potential or reduced activity levels, or both. Providing pureed foods as part of the feeding, even though they are delivered by tube, may improve oral feeding tolerance when oral feedings are desired either for pleasure or for eventual complete transition. Now let us turn to the special products. Extensively hydrolyzed protein products will likely be tolerated by most infants who demonstrate allergy symptoms to cow's milk protein, so this is the primary indication. However, these products also do not contain lactose and 2 contain significant amounts of MCT oil, so they each have other indications as well. Specifically, progestamil is indicated for fat malabsorption in steatorrhea, intractable diarrhea, cystic fibrosis, short bowel syndrome, and severe protein-calorie malnutrition. Nutramigen is indicated for colic due to cow's milk allergy. In part, this is related to the probiotics present in the product. Elementum is indicated for protein maldigestion, fat malabsorption, and it reduces colic due to protein sensitivity. This mention of colic certainly bears a closer look, since colic occurs in about 20% of all newborns. Manufacturers market these formulas for use in colic with relief evident within 24 to 48 hours. But colic has not been proven to be caused by protein sensitivity. Since colic is self-limiting, if the formula is changed by a healthcare provider for colic related to suspected protein intolerance, it makes sense to reevaluate and retrial a contract formula around 4 to 6 months of age. Given that WIC is a food supplemental program, once the monthly allotment of formula is depleted, the cost of the extensively hydrolyzed formulas are about twice the cost of standard formulas. Advancing to an amino acid-based formula increases the cost even more and can be a significant burden for some families. Pediatric products that contain enzymatically hydrolyzed protein are not indicated for use in cow's milk allergy because they are not extensively hydrolyzed products. Pediasure peptide does not list milk allergy as an indication, and Peptamen Jr. specifically states not for use in cow's milk allergy. The amino acid-based formulas, Elecare, Pure Amino, and Neocate, are the formulas of choice for multiple food and severe food allergies, also for eosinophilic GI disorders, malabsorption, and short bowel syndrome. Neocate also lists gastroesophageal reflux disease and FPI specifically, although the literature for GERD recommends trial of extensively hydrolyzed protein or amino acid-based formula. If symptoms of GERD are related to cow's milk protein allergy, 90% of those cases should resolve with the use of extensively hydrolyzed protein formula. However, not all GERD is related to cow's milk protein allergy. The similarities between the products include higher protein content than standard formula, percentages of MCT and LCT, and their availability only as powders. Although all provide more minerals than standard formula, the amounts vary. The biggest difference, practically speaking, is the scoop size for Neocate and Pure Amino. When switching to either of these formulas or when switching back to another formula, we really need to be sure families are well aware of this difference. Neocate and Pure Amino are mixed 1 scoop to 1 ounce of water. Elecare is mixed as are most other formulas, 1 scoop to 2 ounces of water. Although you can access this information just as easily as I can, and none of these formulas constitute major use, I thought it might be of interest to include these numbers here. Thus far, we've had lots of focus on formulas indicated for suspected allergy in infants, but we probably should at least mention what the recommendations are for breastfeeding in these circumstances. Breastfeeding research has more to say about atopic disease, or IgE-mediated allergy. Although exclusive breastfeeding is recommended for at least 4 months if an infant is at high risk for atopic disease, maternal elimination diets in pregnancy and lactation are not recommended to prevent atopic disease, as there is insufficient evidence that this has any bearing on outcome. However, if there is a suspected allergy in the infant who is being breastfed, or if allergy has been confirmed, eliminating milk and possibly soy from mother's diet, since these two are the most common allergies, can be trialed, considering reintroduction of these foods within 4 to 6 weeks and providing dietary counseling for the mother to prevent nutrient insufficiency or deficiency. Turning now to carbohydrate, lactose needs at least some mention since many of the formulas seem to reduce or eliminate the lactose content, and lactose is present naturally in milk. Which formulas are lactose-free? Soy formula, extensively hydrolyzed formulas, and amino acid-based formulas. Pediatric formulas and pediatric peptide-based formulas are low lactose and are thus suitable for lactose intolerance, but are not recommended for individuals with galactosemia. So the question is lactose-free infant formula ever really needed? Yes. Although primary lactase deficiency is extremely rare in infants, both parents must provide the lactase deficiency gene for this to occur. The primary symptom includes profuse watery diarrhea when the infant receives any feeding that contains lactose, including mother's own milk. The incidence of galactosemia varies somewhat by ethnicity, but also requires a defective gene from each parent, so it is also very rare, occurring 1 in 40,000 to 60,000 live births. A secondary and usually quite temporary lactase insufficiency sometimes occurs because lactase is produced at the tips of the microvilli. Episodes of diarrhea can cause some sloughing of the cells that produce lactase. However, these cells quickly regenerate, so a formula change is not generally needed, and breast milk provides enough advantages such that a formula substitution is almost never needed. Fat-modified products include those that are modified in either the amount or the type of fat. Boost Breeze is fat-free and may be used when a clear liquid diet is needed for pediatric patients, to initiate feedings when fat is poorly tolerated, or for patients scheduled for surgery. It is not a complete diet lacking essential fatty acids and calcium, but it is a good source of protein and calories, which is often difficult to achieve when dietary intake needs to be restricted to clear fluids for a time. Enfaport is a ready-to-feed liquid product that limits long-chain fatty acids to less than 15% of total intake and is indicated in the management of chylothorax, a condition that can occur spontaneously, but most often occurs related to cardiac repair if a lymphatic vessel has been inadvertently nicked during surgery. Enfaport is also indicated for long-chain 3-hydroxyacetyl coenzyme A dehydrogenase, or LCAD deficiency, a rare condition that prevents the body from converting long-chain fatty acids to energy. Ketocal is sometimes used in the management of intractable seizures, pyruvate dehydrogenase deficiency, and glucose type 1 transporter deficiency, when carbohydrate intake must be minimized. Many products contain MCT oil as part of the fat content. Although we've mentioned the fat content relative to the indications for various formulas, I've pulled them together on one slide for easy reference. Although the products intended for use in preterm infants have very specific and limited indications, I would like to at least mention them for easy reference. There is a human milk-based human milk fortifier currently being used in some NICUs, but its greatest advantage is in the young preterm infant and would really be cost prohibitive in the outpatient setting. The most commonly used human milk fortifier are cow's milk protein and whey-based, contain some corn syrup solids, and both LCT and MCT to provide an additional 4 kilocalories per ounce when added to human milk. They also add minerals and vitamins, but in and of themselves are not a nutritionally complete feeding. Human milk fortifier is formulated to supplement the nutrients in breast milk and replicate what the infant would have received in utero from the placental supply of nutrients, so it is not intended for use in term infants. If human milk fortifier is needed beyond hospital discharge, as for infants with low serum phosphorus levels, or osteopenia, or intrauterine growth restriction, it is usually needed for a limited amount of time and is typically arranged by the discharging hospital. Hind milk, powdered or liquid concentrate formulas can be added to human milk if a higher caloric density feeding is needed for term infants. Preterm infant formulas are rarely needed after hospital discharge, as they are indicated for infants less than 1850 grams or 4 pounds, although infants who might require higher mineral intake may receive a preterm infant formula until they reach a weight of 3,600 grams or 8 pounds. Protein type is similar to other infant formulas, though it is proportionately higher in amount. Carbohydrate is divided between corn syrup solids and lactose, and fat is a combination of MCT and LCT. The greatest benefit of enriched formulas is for infants less than 1,250 grams or 2 pounds 12 ounces birth weight. But brain tissue demonstrates considerable growth and maturation from 35 weeks gestational age until term, so it makes sense that protein, fat, and other nutrient needs may still be increased. The composition of enriched formula is about halfway between preterm infant formulas and term infant formulas. Instead of trying to replicate the placental supply of nutrients, these products are intended to replace deficits accrued during hospitalization. The biggest question is, how long should we use enriched formula? Studies recommend using enriched formula for preterm infants until 9 months corrected age or 12 months chronological age. But infants who experience greater growth delay during their initial hospitalization, especially in head circumference, may have higher nutritional needs for a longer period of time. And sometimes it is hard to know if and when catch-up growth is completed. A reasonable definition might be that both length and weight are at or above -1 standard deviation based on corrected age, and weight for length should not exceed +2 standard deviations. So ends our whirlwind tour through the products and on to some real-life situations involving some common feeding problems. Jackie is a 2-week-old female born at 40 weeks gestation. Mom presents to your WIC clinic with a description of recurrent, prolonged, unexplained crying episodes and wants to try a different formula before everyone in the house goes crazy. What do? Colic, what is it? In an otherwise healthy, well-fed infant, recurrent, prolonged, unexplained crying, diminished soothability, increased restlessness, crying for more than 3 hours a day, more than 3 days a week, and for more than 3 weeks. 20% of all infants, regardless of sex, race, and socioeconomic status, even birth order, have colic. It begins at 2 to 3 weeks of life, it peaks at 6 to 9 weeks of life, and resolves by 12 to 16 weeks. So what causes colic? It is really a diagnosis of exclusion. It's probably related somewhat to the immaturity of the GI system and an immaturity of the central nervous system. It could be a difficult infant temperament. It may be due to parent-infant interaction problems, parents misreading cues, or parents not responding in a way that matches the infant's needs. Sometimes juice is started prematurely, and it could be a carbohydrate malabsorption. Or it could be cow's milk or soy protein allergy or intolerance. So, what to do? Refer to the primary care provider to rule out serious causes for excessive crying: subdural hematoma, meningitis, otitis media, fracture, etc. But most importantly, acknowledge the difficulty the family is having. Provide coaching regarding early hunger and satiety cues and how to know if the baby is underfed or overfed. Eliminate juice if the family has started giving juice. It is reasonable to try gentle ease as the protein is partially hydrolyzed and produces a smaller curd. But if colic is thought to be related to cow's milk protein intolerance or suspected allergy, extensively hydrolyzed protein formulas may work well, though standard formula can be retried once colic normally is expected to resolve at 12 to 16 weeks of age, or at least by 4 to 6 months of age. If food protein sensitivity is suspected in a breastfeeding infant, a 2 to 4 week trial of milk, soy, egg, wheat, and nut-free diet may be of some use, although be sure to counsel mother on meeting her nutrient needs with these restrictions, and reintroduce these foods individually at 12 to 14 weeks, or at least by 4 to 6 months of age. Our next case study is Theodore, who is a 3-month-old male with a history of vomiting. He vomits within 10 to 20 minutes after nearly every feeding. His growth is within normal limits. In fact, his weight is at a higher percentile ranking than either length or head circumference. What do? Emesis, when is it a problem? There's a normal gentle sloshing up and out of the mouth, 1 to 3 tablespoons amount per feeding, and growth is within normal limits. But if it's a problem, there's usually either projectile or forceful vomiting, more than 3 tablespoons for feeding. Growth may begin to falter. Emesis may include bile, blood, or coffee ground appearance. There may be recurrent upper respiratory tract infections, and there may be concurrent diarrhea. What causes emesis? When the position of the gastroesophageal junction is above the diaphragm, the pressure gradient that normally keeps gastric contents in the stomach doesn't work well. This can be normal positioning until 4 to 10 months of age, which makes it no surprise that gastroesophageal reflux occurs in up to 67% of infants up to 4 months of age. But emesis can also be due to foodborne illness, gastroenteritis, allergy, or intestinal obstruction, so it can be quite serious. What to do? Refer to the professional care provider, especially if growth falters. But if growth is not affected, this might simply be overfeeding, misreading hunger and satiety cues. Watch a feeding if you can. Check to see if the infant is making a tight seal on the nipple or if the infant is gulping air when swallowing. Burp frequently and avoid jostling after feedings. After these techniques have been addressed, consider a trial of Enfamil-AR. If GERD, gastroesophageal reflux disease, is suspected, this involves growth failure, esophageal pathology, or respiratory symptoms. If this is suspected and thought to be due to cow milk allergy, a 2 to 4 week trial of extensively hydrolyzed protein formula should resolve symptoms, although an amino acid-based formula may be needed in some cases. Monica is a 7-month-old infant who just finished a course of antibiotics for an ear infection after an acute episode of gastroenteritis. She continues to have up to 6 loose, sometimes watery stools a day. Mom is exhausted from washing and sanitizing everything. What do you do? Diarrhea, what is it? Stools that are frequent in number, large in volume, and loose to watery inconsistency. What causes it? Poking around in a dirty diaper doesn't sound like a lot of fun, but it can reveal a thing or two about what might be causing a problem when there is one. Malabsorption of carbohydrate generally makes for a watery, acidic stool. Malabsorbed fat makes the stool appear large and bulky or greasy and unusually foul-smelling. Pale, white, or gray-colored stools may be the tip-off that bile salts are not present. Bile salts are needed for micelle formation and thus fat absorption. If protein malabsorption is present, stools may or may not contain blood, but there are usually other symptoms such as vomiting, atopic dermatitis, or wheezing. Again, refer to the professional care provider. If the stools seem to indicate carbohydrate malabsorption, consider a lower lactose formula such as Gentilese, perhaps even Prosobi, especially if the skin in the diaper area is particularly excoriated. But it is also reasonable to retry standard formula. Changes in formula to address suspected fat malabsorption are medical condition specific, but may require that at least some of the fat is provided as MCT. As for other symptoms of suspected food protein allergy, the formulas of choice will be the extensively hydrolyzed or amino acid-based formulas, depending on the severity of the symptoms. Though we have covered a lot of ground today, I hope you found the information useful in identifying the compositional differences and indications in the formulas available to your clients and in handling some of the infant feeding problems you might encounter on a daily basis.
Thank you, Jan, for the great information you provided, and thank you all for joining us for this 2017 Formula Update. This presentation has been pre-recorded. Please address questions to myself at Kevin Sarb, email sarbk@michigan.gov, phone number 517-241-4404. The first thing I would like to do is provide formula updates by manufacturer. Previously, we announced that Abbott was going to introduce 2 new flavors of Ellacare Jr., chocolate and banana. Abbott recently made us aware that this has been delayed. No new date has been announced. Additionally, Pediasure Peptide 1.0 and 1.5 have been slightly reformulated. The MCT to LCT ratio has changed from 50-50 to 60-40. In addition, the international units of vitamin D are changing from 125 to 237 IU per 8 ounces of Pediasure Peptide 1.0 and from 188 to 237 IU per 8 ounces of Pediasure Peptide 1.5. Mead Johnson announced that label graphics will be changing on all Michigan WIC authorized infant formulas. These changes will be reflected on the next printing of the infant formula insert. The owl has been removed and the Reguline label color will change from peach to teal. Originally, all the changes were going to occur in mid-May, but we recently learned that some have been delayed through mid-September. Nestle has announced a new product called Peptamen Junior High Protein. It is a 1.2 kilocalorie per milliliter product, and 16% of the calories come from protein. For comparison, Peptamen Junior has 12% of the calories from protein. We will consider this product during our next formulary review. It is designed for critically ill children ages 1 to 13 with higher protein and energy needs. Nutritia came out with a new product last fall by the name of Neocate Cineo Infant. It contains a blend of short and long chain fructooligosaccharides, and which are prebiotics, and Bifidobacterium breve M-16V, a probiotic. We will also consider this product during our next formulary review. Cineo is the only amino acid product with pre and probiotics. I'd like to talk a little bit about formula indications. When you receive a request for a special formula and are uncertain whether it is the correct product, it is also best to check the indication for that formula using Formula Help in my WIC. Currently, Neocate Infant is the only authorized infant formula with a GERD indication. However, as in most instances, there are exceptions. Nutramigen and Similac Elementum can be approved with GERD as a qualifying condition. The justification for this is that most symptoms resolve with an extensively hydrolyzed formula. After consulting with experts in the field and reviewing the literature, we learned that the majority of infants with milk protein allergy or sensitivity symptoms resolve with an extensively hydrolyzed formula. The rest will need an amino acid formula. Additionally, Similac Elementum Similac Elementum ready to feed can be approved when medical provider requests ready to feed formula. This is because a corn-free version is manufactured only in ready to feed. The medical provider should address this on the special formula food request form by indicating something like a suspected corn allergy. Many times a special formula food request form is received with failure to thrive checked as the qualifying condition for a special formula. After assessment, in consultation with the medical provider, the CPA-RD has two options, approve or deny. While we all feel that some special formulas are overprescribed, I would urge you to err on the side of caution. A discussion with the medical provider could shed some light on the client's condition. The medical provider may not realize that for an 8-ounce formula, issuing the maximum would result in 3.6 bottles per day. The medical provider may be willing to agree on 1 or 2 bottles per day. If the client has previously been issued supplemental formulas to address growth concerns, a component of your assessment and documentation should include the redemption of the formula issued and information from the caregiver on consumption of the redeemed formula. This can help in your critical thinking and determine next steps. What can you do if you are unsure of the appropriateness of the formula? First would be to consult with the medical provider. Another would be to issue 1 or 2 months of formula and bring the child back for a weight check. What you should not do is change maximum to 1 or 2 bottles per day without consulting the medical provider. You should also not change the expiration date unless the cert end date occurs prior to the expiration date. Also, cost should not be a determining factor. While we are expected to think critically and be fiscally responsible, a formula should never be denied when clinically indicated based on cost. This same thought process can be used for any special formula. I like to keep pages from policy over my desk for ready reference. This includes WIC Policy 7.02, page 3, which lists the conditions under which a ready-to-feed formula can be issued. These include documented unsanitary or restricted water supply, poor refrigeration, the infant's caregiver having difficulty in correctly diluting powder or liquid concentrate formula, or the product is manufactured in ready-to-feed form only, as was mentioned previously. Another policy reference to keep handy is WIC Policy 7.03, page 2, which describes what occurs when the medical provider requests that no food be issued to the infant after 6 months, or beginning at 6 months. Fully formula-fed and partially breastfed infants 6 through 11 months age whose medical condition prevents them from consuming supplemental foods may receive Class 1, 2, and 3 formulas at the same maximum monthly allowance as infants 4 to 5 months of age. This would be in lieu of receiving supplemental foods, and medical documentation is required. One I also often refer to is WIC Policy 7.03, the section titled Special Instructions, which begins on the bottom of page 6. These are: clients receiving Class 3 formulas will be designated as high risk. Electrolyte or oral rehydration solutions, such as Pedialyte, shall not be provided to WIC clients by the WIC program. Similac NeoSure and Enfamil Enfacare are available only to premature or low birth weight infants who have reached 4 pounds until catch-up growth is complete, or until 9 months to 1 year adjusted age. Similac Special Care 24 with iron and Enfamil Premature 24 Cal are available to premature infants until the infant reaches a body weight of 8 pounds. Enfaport, Elecare Infant, Neocate Infant, and Similac PM6040 may be assigned up to 1 year adjusted age for premature infants only. There are special formulas without formula packages. These include Enfamil Premature 24 Cal, Similac Special Care 24, RCF, and Similac PM6040. In order to assign a formula for which no formula package exists, the following process should be followed. For an infant 0 to 5 months, any formula package can be customized. You would enter a quantity of 0 for the formula in the package, search for the special formula, highlight the row and click OK. The special formula will be brought in with the appropriate quantity. Then click Assign. For infants 6 to 11 months of age, you could assign IBP, IFF Infant Cereal Fruit Vegetable Only package, and then customize. Search and select the requested special formula. Similarly, an existing formula package could be used with the quantity zeroed out and the special formula brought in as in the previous example. Some special formulas require special attention when assigning to clients. Unique formulas, seldom issued, require assistance from the local agency or CPA to help the client redeem through a vendor pharmacy. National Distribution Code, or otherwise titled NDC, is the best way to determine if a pharmacy can order the product, especially if there are a variety of flavors. So you would contact the pharmacy and ask the pharmacist or pharmacy tech if they can order the formula by using the NDC code rather than formula name. You would be able to access a list of NDC codes in the resources attached to this website. This results in less chance of error. Many pharmacies, including Walmart and Meijer, use McKesson as their medical distributor. Kroger and CVS utilize Cardinal as their medical distributor. When clients report difficulty finding a pharmacy able to order a special formula, one thing you can do is Run the formula usage report to find other clients redeeming that formula. The path is Reports Participation Formula Usage Report. Look up the family ID with a W at the end in EPIC to find the vendor currently redeeming the formula. If no other client is listed, you could call the de jour line for assistance. I'd also like to talk about the Special Formula Food Request Form, as we get many questions regarding this. When a request form is received, take a look at Section 1. Other than for premature birth or failure to thrive, qualifying conditions, when other qualifying condition boxes are checked, the diagnosis should be specified. The qualifying medical condition must be noted in the record and the risk assigned at the next certification or C-eval or I-eval. Best practice is to add the medical condition and assign the risk when the form is received. When looking at the qualifying conditions checked and specified in Section 1, were all medical conditions included in the risk assessment? If not, it should be documented at the next certification or evaluation. By policy, a competent professional authority of the local agency shall determine the nature of a person's nutritional risk as part of the health nutrition assessment at each certification, recertification, infant-child evaluation, and at any appointment when appropriate, such as a change in medical condition that requires a Class 3 formula. All qualifying conditions should be included in the risk assessment at the time of certification or at the mid-cert evaluation. Here's a screenshot of the medical condition drop-down and the nutrition and health summary screen where the risk is assigned based on that checkbox. Also, make sure the high-risk box is checked on the nutrition and health summary screen for Class 3 formulas. Clients receiving a Class 3 formula should be designated as high risk. Section 2 asks the medical provider to list the formula or formulas requested. The box should be checked if they would like the client to have the maximum allowed. Otherwise, a specific volume must be requested per day. If this section is not completed, it would be necessary for the medical provider to resubmit. The qualifying condition should coincide with the formula indications. This can be found by clicking on Formulary Details when using the Formula Search screen under Help in my WIC. As a tip, once the client category is selected, just putting in a partial formula name will bring up the formula for which you are looking without putting in the category of the formula. An example would be to type in splash if you are looking for EO28 splash. Requests for whole milk also need this section filled out, as whole milk can only be assigned to a woman and children 2 to 4 years of age if a Class 3 formula is also requested. In Section 3, the medical provider needs to check all if there are no foods contraindicated. Otherwise, they should restrict specific items. If nothing is checked in Section 3, then the form would be considered incomplete, and the local agency would need to contact the medical provider to clarify if all foods are allowed or if certain foods are restricted. If restriction is checked and the subheading box All is also checked, no food should be in the package. If there is a contradiction in the foods allowing all foods when there's a specific formula that is for food protein allergies or sensitivities, you may want to check back with the medical provider to determine if they really want all foods to be issued. If there is a contraindicated food, there should be information on the medical form, on the medical documentation form that says allow these foods because they want to introduce them through the time so that they can see if there is still sensitivity. Please make sure that all the items on the food package assigned are appropriate based on the request form. You should also check to ensure that the food package assigned matches the information on the special formula food request form. In the previous example, the medical provider indicated that only formula should be issued, so all food needs to be zeroed out. Section 4 is for those clients who have a need for a milk substitution in the food package. If the request is for whole milk, a note states that whole milk is only allowed if the woman or child 2 years or older is also receiving a special formula. This is based on USDA regulations. Soy beverage in place of milk or cheese for a child can be selected for children receiving a special formula. Soy beverage can be requested for qualifying medical conditions. It can also be requested when the child is in a family that follows a vegetarian diet or requires a soy beverage due to religious or ethnic practices. Soy beverages for children not receiving a special formula do not require medical documentation. However, the reason for the soy beverage should be documented in the record. In Section 5, the duration is required. In addition to Section 5, the medical provider should fill out the contact information completely. This area was designed to accommodate a medical provider's stamp. The form must also have a signature and a signature date. The duration and signature date determine the expiration date in my WIC, unless the cert end date is sooner. The section titled WIC Use Only was developed so that the WIC agency could fill it out when they would like to. Since the MyWIC system does not track when a formula is not approved, it was felt that it could be documented directly on the form, and the medical provider could be alerted as to the reason why the special request was not approved. This would become a part of the record when the form was scanned into MyWIC. It's also acceptable to document the reason not approved in the MyWIC notes. Finally, the last line is for the local agencies to indicate a phone number to call for questions and the fax number to use to return the form to the local agency. To determine the appropriate expiration date, add the number of months for which the special formula is requested to the date of the medical provider's signature and subtract 1 day. It is also important to note that all 3 lines should have the same expiration date. I have found some instances where CPAs mistakenly think that the expiration date should be this package end date. Clients receive a postcard a few weeks prior to the expiration date. So in that case, they would receive a postcard prematurely reminding them to get a new form signed by the medical provider. Thank you for your time. Please submit any questions to myself, and I will get back with you within 48 hours.